here. Okay, well, let me start with this case. So this was an 81-year-old female who presented to the emergency department with chest pain, and she immediately went to CT because it was sort of a back pain. So they were very concerned about an aortic. I should probably share my screen. Sorry about that.
Hold on 1 second. I don't think I see your screen yet.
Yeah, no, I
Not seeing anything
forgot
yet.
to hit the share button. Now you should see a CT.
Yeah, good.
Okay. So she presented with this chest pain that sort of radiated toward the back. So they were very concerned about an aortic dissection. Sounds like a good, story, an 81-year-old. So they went right to CT.
Jeff, I think you faded out audio-wise.
Oh, okay. Can you hear me now?
Yeah, Jeff, we can hear you.
Okay. Yeah, I apologize. I'm across the world, so it may be spotty.
Let's see if we can send him a message.
Oh, all right, so let's pause. Action. All right, let's try this again. So back pain, looking for an aortic dissection. Hold on, hit play. There we go. So you should see a CT. So this was done for that. There's no acute aortic pathology, but what was noticed by our resident was this decreased perfusion or attenuation in the anterior wall of the left ventricle, and you can see it persists across multiple slices. And so that would be an LAD territory lesion, and there is a plaque here, and then really very little filling at that area. Here's a reformat just showing that septum in that area of the wall there. So this is an acute MI, or probably an acute on chronic MI, and the reason why it's probably acute on chronic is there's quite a bit of thinning of that apex there. And so this patient was diagnosed with acute MI, and I've got some of the angiogram images here. I could run them, but you can see that right there, there's bad LAD disease. So this was then they did an EKG, and this was a non-STEMI. Went to the cath lab and saw this here. So an acute on chronic MI, but I think the important point is in female patients, the presentations are often atypical. And interestingly, there was just an article late last week talking about the rise of myocardial infarction in younger women and how it's a misdiagnosis, primarily because of the atypical manifestations. They don't get the classic chest pain, crushing elephant on the chest, radiating to the left arm, like we're all taught in medical school in males. And so they may have back pain or sort of a vague sensation, nausea. So it has to have a high index of suspicion. She was 81, so the pretest probability goes up with age. But we can see this occasionally on PE studies. This was an aortic study, but in our institution, there's not a lot of difference between the two. So, okay, everybody see that one? Okay, and you can still hear me.
Good.
All right. Well, why I still have a good audio? I'm curious what you think about this case. We talked about this case last week. One of my colleagues saw this case. I can't remember. I don't know all the history about it, but this is a patient who saw a pulmonologist and has a CT that looks like this. So there's thickening of the right upper lobe bronchus. You'll see there's posterior wall involvement. There's some calcium. And the bronchus intermedius and middle lobe bronchi are also thickened. And there's this high attenuation wall. If I switch over to the lung windows, we'll see there's these funny cystic spaces. There's a little bit of emphysema. But there's also these sort of look like perivascular cysts. And this one even has a fluid level in it, and this really striking bronchial wall thickening, some inflammatory stuff, or some high attenuation around these airways. And then you'll see these cysts clearly perivascular and basal predominant. So I think in our discussion and what my colleague came up with was probably, what the only way to really tie this all together would be LIP or amyloid with cysts, nodules, and tracheobronchial involvement. But I don't recall. I mean, I think the airways are a great look for amyloid, and I don't disagree one bit. But I don't recall seeing a case of airway amyloid that also caused lung involvement, short of just the obstructive phenomena.
Yeah, it can happen. Not common, but it can happen.
Okay. Yeah.
Jeff, you're just referring to calcification of the airways or airway thickening in addition to cysts?
And it spares the trachea, and you know I've seen plenty of cases of tracheobronchial amyloid. They all kind of look the same, but you can see it has that same look, the lumpy, bumpy, the spotty calcification. It's just it's more in the peripheral bronchi, and I have seen asymmetric amyloid, and I've seen it confined to one lobe. Patient hasn't had a bronchia. That'll make it pretty easy. They can just do a transbronchial biopsy, but in our group discussion, that was sort of the best diagnosis we could come up with to tie this all together. And whether it's truly LIP with amyloidosis or if it's all amyloid causing cysts, nodules, and airway.
I remember at least one, if not two cases where there were tracheal nodules in addition to cysts. Now, the degree of airway involvement wasn't nearly this profound, but I know I've shown at least one case where both the airways and the lung parenchyma were involved in amyloid. But yeah, I agree with Howard. It's not very common.
No, it's usually isolated to the tracheobronchial tree. I mean, when you see that. Yes, and that patient was 58.
Very interesting.
Female. So I'll follow up with you guys once we get a bronchoscopy and some biopsies. But none of us could come up with anything better to tie it all together. And I don't know what's called.
Yeah, amyloid ties it together very nicely.
And whether there's an underlying plasma cell dyscrasia is unclear. Okay,
exactly.
This is
have to do the usual amyloid.
Yeah. So this is a nice case. This is a 41-year-old female who I don't have a chest radiograph for, unfortunately, but has this finding on CT. So there's a mass in the mediastinum. Now, where you're going to localize it, I would put it probably still in the prevascular compartment, but it's sort of on the border. And at first look, it looks pretty low attenuation, but then if you look carefully, it's a little denser than normal. And then there's some very subtle areas of, and some of this may be volume averaging. This is an outside scan, so the slices are a bit thicker. But it's a little denser than just a pure cyst, and it's a little heterogeneous. So for mediastinal masses, in reality, I mean, I don't think any of us would think this was the lymphoma. So in all honesty, you would just take it out. I mean, the only reason to do any other imaging is if you thought it was a benign lesion that you weren't going to do anything with. But I think there's enough convincing solid component that, this is probably, statistically in a 41-year-old female with a mass like this going to be a thymoma, even though it's a little more posterior, and you would just take it out. But we did do an MR, and it may help the surgeon as far as planning goes, whether or not it's invading or what's its relationship to the pericardium. So I have some MR images. Let me scroll through these here. So the cine images are nice because they show that the mass, the heart is sliding right next to the mass. So at least on those images looks okay. And it's not cystic. Let me jump ahead here. They did do, I got some, here we go. We've got some we did some tagging. Here we go. Let's see. So with this, you can see, that's the wrong plane, but you can see, the mass, the heart slides right next to it. So that favors that it's not, it's not adherent to the pericardium or invading through the pericardium at least. You can always peel it off, but that it's not in there. So it's a nice use for that. And then they did some of the nice tagging images. You can see that the tags break, which tells you that the mass is separate from the moving components of the heart. I don't know how to slow down the rate, but so just some nice things you can do with this. And then just some other images here showing showing that the mass is separate from it. So this ended up being a thymoma. They biopsied it somewhere, but in reality, you would just take it out. So MR can be useful in some cases. I'm not sure how helpful it was in this case. Some of the surgeons like it, some don't. But there's a couple tricks you can do on selected cases. All right, so this is kind of the exciting case of the week. So this is a 36-year-old female who was recently pregnant and developed some chest pain or symptoms after her delivery. Baby was fine, everything like that. and got the CT in the outside, and we see this very strange collection of contrast in the upper mediastinum. Now, there was a procedure. That's what some of the air is from. And then you'll notice there's this soft tissue mass with these calcifications in it. And then there's more of the mass. Whoops. So this is a part of the CT. And let me show you the other portion of the CT. I don't know why the series was broken up. Let's try and find it. Here it is. Here's another scan, but just showing there you go. You can see all this contrast from the SVC seems to pool in the mediastinum. And as we go down, you see this funny vessel right there, punctate calcifications that look like phleboliths. There's fat in the mass. And then as I go in the upper abdomen, you'll see it's actually around the lower aorta, along the liver there. So all these calcifications. So this is a massive venous malformation. It's got phleboliths, so that tells us it's venous. And the thought is that this thing ruptured probably during delivery when there was increased intrathoracic pressure, and it's a contained rupture of the SVC here. There's an MR too that, let me see if I can find the right sequences here. T2 coronal. Just shows more of the mass. You can see there's a lot of fat in it as well. Very complex, goes in the retroperitoneum. But I think the best images is this image right here. This is the SVC venogram, and you can see there's just this pooling of contrast right there. You can see the turbulence in there. So you're very complex. This has been there for a while. She didn't know she had it. So she met with one of our interventional radiologists, and the plan actually is to put her on sirolimus to try to just keep this thing in check and just follow it. But this is one of the more crazy ones I've ever seen. I don't know, but it's got all the good features of it. You can see just how it's, I mean, it'd be hard to, you can't resect it because it's too complex, but it goes in the retroperitoneum, around the liver, and then passes through the diaphragm. They did something at the outside hospital. I'm not sure exactly what they did, but they tried to decompress some of this. She had a sternotomy. And then here's a radiograph post some intervention. You can see it's a lot smaller than one would expect from the original imaging. So she'll get followed up in a year. But this is one of the craziest vascular malformations I've seen in a long time.
So in many respects, it has some features one sees with large mediastinal hemangiomas, which may have phleboliths.
Mm-hmm.
But then in other respects, it ended up communicating with the SVC.
Yeah, here's a coronal. Yes. And the thought is it ruptured and find the CT again. Where did it go? Sorry, it's like, yeah, so it presumably ruptured. And if I go back to that other CT image, let's see, is it this one? It's this one. There was a funny vessel right there. There's this funny vein right there. So I'm the classification of these has changed over time, but I think because it has phleboliths, it's now considered a venous malformation, and it may have some hemangioma features, but clearly there's a big vessel here as well, and it's hard to know where this thing's coming from, but it is at this point communicating with the SVC, which that's what they repaired externally, that communication. So
that is
ruptured. Yeah, pretty crazy.
So Jeff, did she had acute symptoms
not
at the time of her pregnancy?
That's not my understanding. Is this was postpartum? So
is there any chance that is not a rupture and that's just how it's been pooling and collecting?
It is absolutely possible. But I've never seen a big pool like this. I mean, it sure looks like a contained rupture on the venogram.
I agree, but there's no like reactive effusion or real stranding around it or anything.
And so, and I can't remember how far postpartum she is. This is an acute, so it's possible that if there was a reactive thing, that's already sort of resolved.
Those images are the strengest things
right there. You can see it, and you see the smoke right as it flows in right there. But yeah, it's just sure looks like a continued rupture to me.
Wow.
Okay.
That is strange.
All right, here's another
case. Can be very large and very sort of infiltrative. They grow between structures, but that vascular connection obviously is really strange.
And I don't know if this is true, but you wonder if the being pregnant at all stimulated growth of it as well. Because I mean, she's 36. You know, it's been there for some time. All right, here's my last case. So this is another fun vascular case, and this was one of these great on-call cases where you're glad you have a good resident. So this patient, he's how old is he? He's a 57-year-old male, and he was actually, this was done as a late outpatient from vascular surgery. He had been referred for sort of intermittent claudication of his lower extremity, and I don't remember all the details about him, but you know, I think he had risk factors. If I recall, he's a smoker. And so this is a CT runoff. And you can see he's got some atherosclerosis in the pelvic arteries. Nothing horrendous, but definitely has some plaque, which you wouldn't expect to see in a patient of this age, unless other risk factors. But what he had was down in the popliteal artery, and just below is this right there. There's a filling defect, and it's not associated with any plaque. You'll see there's no real calcification, and right there you can see it in the middle, and it just kind of goes over a fairly long distance, and then there's perfectly fine 3-vessel runoff, and there's really no distal plaque. So it doesn't look like an area of atherosclerosis, but looks more like an in situ thrombus or an embolus. And the important thing is, in these runoff studies, of course, is we frequently or usually get a big, we get the whole abdomen in there. And, you wonder, you look at the spleen, and we're arterial phase, but there are a few areas of peripheral low attenuation. Hard to say if that's anything short of mixing. I mean, we're still very early in this case. But he has pulmonary embolism. So putting it all together, there's, unless he's got a bunch of in situ thrombus, you'd have to wonder about a right to left shunt. And it's very subtle, but, to my resident's credit, she suggested a PFO. I don't think she appreciated one because it's pretty subtle. But when I was looking at this, I noticed there was sort of this high attenuation contrast mixing, because you can see that we should be pretty mixed in the left atrium by now. But there's this just little bit of high attenuation that doesn't belong there. And so, I mean, almost certainly there's a PFO, and it was confirmed on echo. So this is a paradoxical embolus that started with a pulmonary embolus that led to a lower extremity embolus. And no, we've seen
interesting.
Yeah, Julie sent us a case years ago of one hanging over the PFO, a clot right there at the shunt. Okay.
Very interesting.
Yeah. So let's see. Well, yeah, that's it for the week. So that's what I have. And I don't know, Howard or Travis, if either of you is ready, or David.
I could show some.
All righty. Let's see.
Can we all feast our eyes on a röntgenogram here?
Yes.
Great. Okay.
Okay. So this person has a slightly big heart, and it's been bigger at times in the past. At this point, his heart size has decreased a little bit. He does have an abnormality that looks like some peribronchial scarring here in the right upper lobe. And here's a current chest radiograph. This is AP versus PA, but the heart is bigger, and there's enlargement here of the main pulmonary artery, suggesting pulmonary hypertension. And we have this abnormality around bronchi here in the upper lobes, particularly on the right. And here's what CT looks like in this person. There's quite a bit of bronchiectasis, and there's a lot of mosaic attenuation here, indicating that there is, in addition to the large airways disease, the bronchiectasis, there's probably constrictive bronchiolitis causing air trapping. And at this point, without expiration, we're just seeing mosaic attenuation. And seems to have a little like keyhole-shaped trachea that looks as if he's trying to be obstructive, a la saber-sheath trachea. And this bronchiectasis is throughout, and the air trapping is mosaic attenuation is throughout. So it turns out there is an immune deficiency operating here, and this is Wiskott-Aldrich syndrome, which involves an IgG deficiency as well as thrombocytopenia. So I haven't read up on Wiskott-Aldrich. I remember the name from medical school. I don't think I've seen a case of Wiskott-Aldrich, but this is immune deficiency that accounts for the bronchiectasis. And then he does have pulmonary hypertension here from his chronic lung disease. Pretty dramatic. And I think if we go farther down, we see that there's some right ventricular strain, right ventricular dilation, flattening of the septum. Okay, so Wiskott-Aldrich, you guys got a lot of cases of Wiskott-Aldrich. This is my first.
No. So we're describing the airway disease through chronic infections, perhaps, or
From the IgG deficiency component of the Wiskott-Aldrich.
Yeah, if I recall, they have some sort of B cell deficiency, and I think they have a really high rate of lymphoma.
Okay.
And I think it's X-linked. That's all I remember about it.
Okay.
oh,
So I'll try to read up on it when I post it. Okay. So so here's a person who has at this point a normal sized heart, and previous radiograph showed a large heart. He does have a defibrillator. It's a fairly young person, and if we zoom in with CT, we see that first of all, let's do the mediastinal part here. You know, not a small heart, but he's got these this pad of tissue here adjacent to his thoracic spine, and there are a couple of other of those little things here. And then notice the texture of the bone here is a bit flaky. Let's look at a coronal here, and let's look at posterior ribs. And I think you can see that the ribs are a bit dilated. The marrow cavity is expanded, and there's this sort of spiculation here, or little dots throughout here. So this person, let's look at the sagittal here for the thoracic spine. So vertebral bodies are all sort of flattened, a little bit malformed here. Texture, I don't know whether it's a little bit coarsened or not. These bones are not expanded as anything, they look compressed, but look at his sternum here. This sternum is definitely dilated. This is beta thalassemia. And he's got extramedullary hematopoiesis as the cause of those paraspinal tissue deposits that we see back here. So EMH in beta thal, and his spleen is big. That's the other things. So he has heart disease on the basis of this. I don't know whether it's just the anemia or whether there's some other cardiomyopathy involved. And his heart at this point is under better control, so his heart size has decreased from some earlier radiographs where it was much larger. So I don't know what the cardiac effects of beta thal are besides the high output failure from anemia. I wonder if there's excess of iron turnover or something like that, and there might be, maybe there's hematosis involved. I'll have to read up on it again.
it is kind of thing that he's got an ICD device, so they think he might benefit from an anti-tachyarrhythmia device. I have a hard time putting together with the rest of it.
I wonder if he's got conduction problems, or
Yeah,
I don't know.
or
Yeah.
some reason.
Okay, so now is Seth online today? Because the Seth case, and this case was developing a few weeks ago when Seth made the dismissive comments about pulmonary artery sarcomas being a dime a dozen and not even worth saving. So that really hurt my feelings. So this has a little blob out here in the lung on the left, and that's about it. The mediastinum really looks okay, but check out the pulmonary artery problem. This is all outside imaging, and there's this very large filling defect here in the left pulmonary artery. It seems to fill up most of the left pulmonary artery. And then we get down near the valve, the pulmonic valve, and it's not visible here. There was a little nodule associated with the pulmonic valve, and then this is, there was a workup that included a PET scan and MRI and stuff like that. It was very ambiguous whether this was tumor or thrombus, and the imaging was not definitive. So we had this raft of outside imaging before the person got here. But by the look of this thing, it really looks more like a sarcoma to me than it does like a thrombus with an attachment to the posterior wall. So this thing got larger in a couple of months. So our imaging showed increase in size, and ultimately this was resected, and it was an intimal sarcoma of the pulmonary artery. And the PET scan showed that one of these blobs, that's not definitive. It could be tumor, or it could be, you know, a reasonably recent infarction. Those would both be hot on the PET imaging, and the PET imaging showed modest uptake in this mass here in the pulmonary artery, and the same modest uptake in this peripheral lesion here. So this person was treated then with pulmonary artery resection and left pneumonectomy, and is due back for another a follow-up scan in a month or so, but prognosis is pretty grim. Okay, so
David, how's the right ventricle doing on that study?
How's the
right ventricle? Are they fairly well compensated? Because I think that's like what we were talking about before. Is it
right?
It's a little dilated, but it's certainly not like an acute PE right heart failure look.
But there is flattening of the septum here, and
yeah,
it's hard to tell about pulmonary artery being large here. Yeah, I think there's at least RV strain. Yeah. Okay, so I did in on a day when Seth wasn't here, so he wouldn't yawn so loudly in my case about this case.
Those blobs sure look like infarcts, David. That picture right there.
Yep, they are very much so.
Yeah.
The other thing that is distinctive about the appearance of the left pulmonary artery tumor is how I use the word scalloped to describe the interface between the lesion and opacified blood. So if you scroll back and forth, you see how scalloped it looks like. Or,
it's lumpy, isn't it?
Lumpy, bumpy scallop. That shouldn't, and it's bulgy. Even that left pulmonary artery, where there's a bit of contrast, bulges.
Yeah.
And I don't think you ever see that with bland pulmonary embolism. That observation alone itself, along with the other ones.
Right.
I
think to have such a large lesion hang up this proximal just doesn't reflect blood flow. I mean, blood flow would carry thrombus more peripheral than this. It wouldn't be bulging up here. It would be spread out downstream, and this seems to be resisting the streaming effect. It really looks.
Bronchial arteries on the left, while they're not huge, look bigger than the one. Well, I can't even see the ones on the right.
Yeah.
Mm.
So,
and then if you throw an ROI there, it's going to be quite a bit more than, say, 40 or 45 or 30. If you just put an ROI anywhere on that pulmonary artery, it's going to be. That makes it higher. I mean, let's go another place a little bit higher up. Because visually it doesn't look low, like somewhere in there. What does that show? Just curious. Yeah, just somewhere.
13.
It's fairly low. 13.
I'm surprised. I'm very surprised, actually. It didn't look that low.
Well, I think it's just because you're early. You're not giving it enough time to enhance. Especially, you see some big bronchial arteries there, so some of it's going to be systemic circulation, which means that the contrast enhancements are going to be even more delayed.
Okay. Visually, it didn't look that low. Okay. Very interesting.
Okay.
Cool.
So then here's a fellow who is shortness of breath. I like this case because this person has a big heart, looks as if there's heart failure, and this person is one of the rare people with left ventricular failure who has cephalization or a redistribution. So vessels pointing upward here are fatter than, or as fat as vessels in the base here. So it's rare to get cephalization short of mitral stenosis. So if you get it from left ventricular failure, it turns out that what it goes with is chronicity of left ventricular failure. So people who are having an acute myocardial infarction do not get cephalization. They don't get a big heart, but they get lung edema and pleural effusions. And it takes the heart weeks to months to dilate, and it also takes vessels a long time to become cephalized or to dilate very much. But what struck me about this case was that there are these funny rings going on here, and here's the lateral view. So I was thinking, I'm always looking for cases of cysticercosis or something like that. So be nice to have some, or echinococcus, that's actually what I meant. So wouldn't that be nice to have that here? So that's what I was hoping for with these calcified rings. But then I thought, to tie this to a heart person, I wondered if these were, if he'd had bypass, but he didn't have sternotomy wires, and maybe these were aneurysms of his grafts or something like that. But he hadn't had bypass. So turns out he has this outside MR study, and I had some experts on MR help me pick out some images to show this. So here are those ring things, and it's black here partly because it's calcified, but I think this is also just artifact of what is it, susceptibility artifact or something like that. But here's one of those rings. Here's another one down here, and then there's this channel that's separating. So these are coronary artery aneurysms that are calcified. And then I looked at the history, and he's got Kawasaki disease.
How old is he again?
He's, I think he's 52.
Wow.
I'll check.
Oh my.
So Kawasaki, who would have thunk?
Yeah.
Okay, and it's visible on his plain radiograph as these calcified aneurysms. Okay.
Wow.
So I'm sorry.
Oh, go ahead. I was going to say, before you move to the next case, David, I'm glad you brought up that cephalization point, because I hear it from the intensivists and the ER docs and some of the radiology techs that are floating around out there talk about this. And I think your point is correct, because it takes time for the vessels have to remodel.
That's right. And so, finally, I think the most definitive statement on this was in 1982 in the JTI article, where this Italian guy said that he views this that it reflects structural remodeling.
Mm-hmm.
And the thing is, once people have cephalization, it doesn't go away, because it's actually a permanent fixed stenosis of the lower vessels, actually, that it's done. So it's not going to go away once it's there.
Right. I've seen it with chronic PE as well, where it just happens to take out the lower lobes. But if we think about most of the ICU patients we see are supine. Right.
And that's so. But I've seen people tie themselves in knots, just force themselves to see cephalization and to see cardiomegaly. It's not there, because they know they're not allowed to have the lung edema unless their heart is big and there's cephalization, because they learned in medical school that the heart dilates, first of all, to compensate for a challenge, and then the vessels dilate, and only after the vessels dilate do you ever get lung edema, and only then do you get pleural effusion. So it turns out that that does not apply in acute heart failure. So if you have an acute MI and your heart was previously normal, you will not have a big heart or cephalization when you have failure and you're short of breath and you have florid lung edema
and
from
you won't have effusion quite yet.
Or if you have an arrhythmia, or if somebody gives you a volume overload, you will get edema, but you will not have a big heart and you won't have fat vessels.
Right.
So acute versus chronic. And what's taught in medical school applies to the chronic heart failure, the Starling curve and all that kind of stuff.
Mm-hmm.
Does not apply in the acute situation. Or if it does, if the Starling curve applies in the acute situation, it's mistaken to mean that you're going to get vascular dilation and cephalization before you get lung edema. So the medical students come in with this information that you're supposed to have cephalization, and I've seen pulmonologists study these exams and say, okay, I'm sure I'm seeing the cephalization, because they want the person to have it before they're allowed to have the edema. Okay, so
before you go on, I want you, before you take that image away, if you put that radiograph back up, I agree with what you say for sure, that this is a manifestation of chronic, not acute pulmonary venous hypertension. Right. And the other thing that your case shows really nicely, and people don't remember this, is if you look at the sites in the suprahilar lung, in addition to making the observation about the caliber of them relative to the lower lung zones, you have two vessels, and the one that is lateral is the dilated pulmonary vein, which is that one. And on the other side, you can see two parallel vessels, and the one that's more lateral ought to be the left superior pulmonary vein. So when you teach inversion of pulmonary blood flow or chronic pulmonary venous hypertension, one should also try to teach the identification of the dilated superior pulmonary lap. But this particular case shows them beautifully.
Okay, and then medial, you think this would be the artery here?
Yeah, that's the usual relationship, is vein is lateral to artery. Yeah.
Good. Very good. Okay. So the last case I wanted to show is this person who has a metastatic papillary called tall cell papillary thyroid cancer to the lungs. And this is an early radiograph from 2014. So he's got lungs full of small nodules, and he got radioiodine therapy. First of all, he had his thyroid, he had thyroidectomy, and then he had radioiodine, I-131. So this is 2014, and this is 2016. This is a year after therapy, and at this point he had a lung biopsy, and we had a pleural biopsy because I think he developed a pneumothorax. But and they looked at this, and they found no tumor, and his thyroglobulin levels have been undetectable. So this is he still looks as if he's got a lung full of mets, but there's no evidence that he has any active tumor. So this is a year after his radioiodine therapy, and he had thyroidectomy. Okay, and then let me bring it up to date. Here's or a little bit farther along. Here is a more recent radiograph, and notice that he still has all those lung nodules. It looks a little messier. They're not discrete nodules so much anymore. It looks as if there could be some scarring in there. And notice this peripheral rarefaction of lung here, and that corresponds to this pretty dramatic peripheral emphysema here. So he's got this emphysematous or bullous process here going on at the periphery of the lungs, and he still has all these little lung nodules, kind of messy looking. Let me show you an earlier CT. Here's 2015. This is just after his radioiodine therapy, about 8 months after it. And let's get a comparable level. I think this is getting pretty close. Notice there were lots of lung nodules, but we didn't have as much of this peripheral emphysema as we have now. So we've got a lot more rarefaction of lung. We already had some going at this point. But I think that has progressed, and the number of nodules has actually decreased a bit. So what's going on here? Let me bring up to a comparable level here. Notice that the AP diameter of the chest has decreased here. Basically, this lung is scarring up, I think from the radiotherapy, the radioiodine. So I think that this is really a manifestation of pulmonary fibrosis, radiation fibrosis, with a bizarre distribution. We're used to through and through radiation that cooks a big swath of lung and has nice sharp boundaries. But this I-131 radiation is really delivered by the beta particle, which has a range of about 3.5 millimeters. And so all of the radiation occurs really in the lung nodules for the most part. And I think that we therefore have these multiple foci of radiation fibrosis through the lungs that have resulted in this contraction of the lung here, the decreased AP diameter, the pulling centrally of all of this tissue, and the increasing rarefaction of the peripheral lung here, this peripheral emphysema. So I think this is really radiation fibrosis in a microscopic distributed distribution throughout the lungs based on the lung nodules. And so what they found when they did the pleural biopsy that got some lung tissue was that there was fibrosis, and there were some granulomas, but there was no tumor. So I think the fibrosis is probably radiation fibrosis in this case, but it's at this microscopic or this disseminated microscopic level. So I tried to find some CT scans of this. If you look up radioiodine therapy complications, you do find pulmonary fibrosis is listed, but nobody illustrated a case. Nobody had CT on a case like this. So He's tumor-free. The nodules are probably just little balls of scar tissue at this point, and I think they're pulling together sort of like silicosis here, and we're getting this confluence of these nodules here, and they're pulling in centrally. He's got restriction and obstruction, and he's got this progressive peripheral emphysema. So what do you guys think of my hypothesis?
I like it. Yeah, I mean, I found a report in the literature that showed they didn't have imaging, but they showed a decline in pulmonary function test after treating that showed a restrictive physiology. So the presumption was there's some fibrosis, and then there's a couple of just scattered articles, but this is impressive. But I like your silicosis analogy.
Yeah, so it's like paracikatricial emphysema that you're showing there.
Well, yeah,
like
partly
fibrosis.
But partly, I think, the fact is that the lungs are shrinking from the inside, and so that they're going to draw centrally like that, and they're stretching the tissue at the edges. So it's partly, it's not quite paracikatricial. It's more peripheral, I think.
And what is the pathology again? What kind of thyroid cancer?
The papillary, it was called tall cell.
Tall cell.
Okay. So tall cell papillary thyroid adenocarcinoma.
Very interesting.
Yeah, and
so if you guys have seen any cases of persisting nodules after radiotherapy and thyroid cancer, check them out and see if this is something we should describe. This is the only case I'm aware of right off. Okay. Those are my cases.
Thank you, David. All right, Howard, you said you had one?
Yeah, I've got one I can show. Okay, this goes over quite a long period of time, but it's really interesting and shows the difficulty of making a diagnosis sometimes. So let me just go back to 2015 and just scroll through the images. And there's some interesting findings there. So there is both cystic lung disease as well as multifocal multinodular lung disease. And some of the opacities are ground glass attenuation, some are part solid. Others that are larger, let's go down and pick out some like here, may have some airways that traverse them undisturbed. So this patient is known to have Sjogren's syndrome. So in looking at this and thinking about lung manifestations of Sjogren's syndrome, the cysts, pretty straightforward, we see that commonly. But in terms of thinking about the nature of the pathology for the lung lesions, it gets a bit harder. So if the lung lesions are all small and just ground glass attenuation, one would think of LIP. But when the lesions are much larger, multifocal like that, I don't like LIP as the sole explanation for the pathology. So let me just now go to put some history and pathology alongside the right-hand side. And now I'm going to show you that in 2015, she had a biopsy. The initial workup was done at the outside institution. So here is a needle biopsy after I think she initially had maybe a transbronchial biopsy. So a thing was biopsied, as you can see there. But again, as best we know, based on the information I have from the outside, is that a non-malignant condition was diagnosed in 2015 on that basis. But not a lymphoma, but she carried a diagnosis for a long time of LIP. Now we're going to go forward 2 years at least, which is at the time that I saw this case. And you can see a lot of the lesions have gone away compared to 2015. But one area that, again, bothered me a lot, based on what I see here, is this one. And I suggested that a lymphoma is definitely a consideration for a lesion like that. What followed was a biopsy, but I think in terms of communication, there may have been some issues because the biopsy that was done around about this time or afterwards was more of an open lung biopsy. Actually, I think I might have seen this one. Sorry, I'm going to backtrack. I think I saw this case when these other lesions appeared. But the biopsy that was done was more an open lung biopsy. So there were two areas that were biopsied. One, as I'll show in a moment, was alongside this lesion. And there was a second biopsy in the right lung because I think the request was perceived as a surgical biopsy for interstitial lung disease, not a directed biopsy for the right lower lobe lesion. So this shows you that it's rather hot down there. So as you can see here, the next biopsy in the report of the open lung biopsies in 2017, again, did not reveal a lymphoma, but a lymphoproliferative disorder. And I was a little concerned about that. So now we have to go forward quite a long time again to show you that at the end of 2018, we now have some lesions that go away, but some get a lot bigger and new ones appear. And you can see here that there's some tissue material, but it's anterior to the lesion that I saw previously. But now we have big and new lesions, and I'll show you that in addition to the lung lesions, that a PET scan will show a muscle lesion, and going through the lungs, you expect to see that, but now this person also has nodal lesions as well as a adenoid or hyperpharyngeal lesion up there. And as you can see here, the diagnosis of marginal zone lymphoma is made. So it took a long time to make the diagnosis. Somewhat puzzling is the apparent disappearance of some lesions, but then they come back again. And that always puzzles me. But I think the findings were not consistent with LIP from the outset. And now we do have a diagnosis of marginal zone lymphoma, as you see there. So a couple of years went by to make that diagnosis. And I think lymphoproliferative disorders can be really hard, and for the pathologist too, under the microscope. But this is the most recent CT for the lungs.
So, any chance the patient got some anti-lymphocytic agents for their Sjogren's syndrome that may account for the regression of some of these markers?
Yeah, I think she's been treated with different anti-inflammatories over time. For example, way back there, she was on Plaquenil, rituximab. That goes back to 15 and 16.
I'm not
really
sure.
not certain. That's always.
I think with some of these low-grade lymphomas, they sort of act like, some of these more indolent lymphoproliferations that some of the anti-lymphocytic agents, even steroids, can make them regress temporarily. And then you end up selecting out, or there's a mutation, you get more aggressive, or you get a transformation, and then they quote, come back.
Yeah. Yep. And I think to the extent that maybe quite a few of these are associated potentially with EBV virus, that maybe the viral load changes over time. So one's inflammatory response to the EBV virus also changes over time, so it can get better and come back again.
Right.
I think that all fits together too.
Yeah.
That's a great case.
So, Howard, we have a case of a marginal zone lymphoma in the setting of Sjogren's disease, and I showed it years ago, and the person is back in the hospital now with huge blobs in the left upper lung and stuff like that. It really looked like fungal lesions. They're slightly bigger than the one you're showing here in the lingula, and that was all considered to be part of her, her lymphoma, and it waxes and wanes.
Yeah, I think it can. I think it does that. I'll have to look up to see whether other cases of marginal zone lymphoma outside of the thorax can behave in the same fashion. That you do have a waxing and waning phenomenon that sometimes occurs at fools everybody.
Cool.
Now, ultimate prognosis may not be affected in a sense by a delayed diagnosis because this is kind of indolent, and she's had it for fun. But very instructive.
Yeah. All right. Well, thank you.
Okay.
All right, Travis.
Okay.
Sorry for taking up all your time, Travis, but we'll give you more.
No, it's fine. We're fine here. So I'm going to show this with the preface that nobody knows what happened in this case, and I'm curious if you guys or anyone that's tuning into this has seen something this kind of like this. It's kind of like FBI Most Wanted. This is a patient who presented with neck mass, and you can see this is a PET back in October. This is biopsied, and this was metastatic adenocarcinoma of lung primary. Presumably the primary is right there, but you can see he's got extensive mediastinal lymphadenopathy at the time of diagnosis. And this was early October. He was started on chemotherapy, had some response, and then they found that he had an ALK rearrangement. So he underwent additional therapy with crizotinib, which is one of these targeted therapies. And in between, so that was done 12 days prior to this CT that I'm about to show you. Let's see if I can actually get this. Let's see. Move it here. So this is 12 days afterwards, and in those 12 days, the neck mass basically disappeared, but this showed up in the anterior mediastinum. And so this was a tumor board, and I didn't know what to do with it, and I said as much. I didn't know if this was some sort of hemorrhage. He was asymptomatic. You know, there's some discrete nodules in here too, whether this was recurrence there or whether they had somehow unmasked some sort of lymphoma or additional thing. You know, so we agreed to biopsy this, and for reasons I won't get into, unfortunately, we weren't able to biopsy it, but he got a follow-up a month later. He was still on the crizotinib, and as you can see, during that time, it, you know, got a little bit, maybe a little bit more organized, maybe a little bit smaller, and then they continued to watch it. Everything else was responding, and then this was just 2 weeks ago, and now it looks like this. And so, and this is without any change in management. He's still on the crizotinib, and everything else is still doing well. And Brett had a good idea looking at this one. It almost looks more like a little bit of thymic hyperplasia. You know, it's a little peculiar, but I have no idea what happened here. And so they're going to continue to watch him just because he is getting better and he's responded elsewhere. So, yeah.
Was there any lymphadenopathy originally from the tumor in this location?
There was just a little, and you can see right here, there were a couple. Like, I wondered if it, you know, are you thinking like some sort of pseudo progression,
Yes,
or?
I am.
Yeah, everything else shrank, and then, I mean, it's just such a massive enlargement. I guess it's, you know, we didn't know because everything else had gotten better.
You know, Travis, it's definitely outside the pericardium because there's fat in it, first of all, and second of all, you see the mass effect on the brachiocephalic vein. You know,
Yeah,
I like the idea of a thymic hyperplasia. Maybe it even hemorrhaged a little bit, but you can get pseudoprogression.
Yeah.
You can also get hyperprogression that then became sort of responsive after that.
Well, and that's what we were worried about too, was hyperprogression or you know, something else like a lymphoma or something that didn't uncover. That's why we wanted to biopsy it, but we weren't able to actually biopsy it.
Notice it's sort of respecting the boundaries of the mediastinum, and it's with the fat in it. I think Brett's right. It's clearly looks thymic.
Yeah, at least this portion of it does too. There's still a little bit more cystic portion there. Yeah,
Right.
It's just, and some of those small little nodules more anteriorly are still there. So I don't know, but that's why I was curious if anybody's ever seen some sort of reaction like this with some of these new targeted therapies.
Wouldn't surprise me.
But yeah, it's just, because obviously he responded everywhere else. And I mean, yeah, I've seen modest pseudo progression. What's the largest you guys have ever seen something increase in size from pseudo progression?
Nothing like that.
Don't.
So at one of the sessions,
usually you think of nodules that increase in size a few millimeters or maybe.
You know, one of the sessions I was at yesterday, they said
Yeah, go ahead.
if the growth rate increases by about 50% or more, then you should favor hyperprogression over pseudoprogression. I'm not sure what that's based on,
So
but it kind of makes sense.
Jeff, what is hyperprogression? I mean, that you
So somehow immunotherapy can actually stimulate the tumor to grow faster as opposed to killing it. So with pseudoprogression, you get an
Yeah, and that's
immunologic response that leads to what looks like a bigger mass, and a lot of it's because you have a bunch of inflammatory cells that are now targeting the tumor. Hyperprogression somehow turns on one of the drivers and causes the tumor to actually grow faster than its previous rate. So the speaker yesterday mentioned that if you know what the kind of what the doubling time was, volume doubling time, say pre-treatment, which we don't often get because we, especially in the U.S., we tend to just start treating. Um, they then if all of a sudden you give immunotherapy and then the volume doubling time increases by more than 50% from the previous volume doubling time, you should favor it being hyperprogression, not pseudoprogression. But a small number of tumors will respond that way.
all right. Well, yeah, if anybody else has seen a similar thymic reaction, because I think that's probably the best bet.
Yeah, I think so.
But
too.
I'm going to show one quick one. This is courtesy of Kim Calianos, my colleague, who just saw this morning. And I'll put up, fortunately, we have a radiograph from last month, and this is an older patient, has a tortuous aorta. And I will let everyone take a look and see. She's been anticoagulated, and then an hour prior to this, developed sudden onset of chest pain.
Right.
And I think this is one of the best examples that I've ever seen of this, where you can see now she has the new displaced intimal calcification, or, more appropriately, I think just stuff around the aortic arch calcification there. And sure enough, this does turn out to be an acute type B intramural hematoma that was just diagnosed this morning. So yeah, so nice radiograph just showing that it's something that we can occasionally see, not common, but definitely evident there.
Nice.
there are more artifacts that look like this than there are real cases. So this is a wonderful thing. Yeah.
So, all right. Well, I'll stop there and show everything else next week.
All right. You can go first next time. Thanks, everyone.
See you guys.
Bye.